In just a few moments, I'll turn you over to Dr. Danielle Johnson. And as you can see, we're going to talk about understanding depression and anxiety after giving birth. But before I do that, I would like to welcome you and say thank you for taking your time. I know we've got folks on some different time zones out there, so thank you for being with us tonight, and we certainly appreciate it. One piece of housekeeping, we would like to ask you to hold your questions until the end. So if you could do that and put them in the chat, Jim and Bob will work with that, and we'll make sure those are asked. They're run by Dr. Johnson. I'm Maria Sulzer. I'm an outreach specialist at the Lindner Center of Hope. We are an 80-bed psychiatric facility and not far from here in Mason, Ohio. What all are we doing there, you might ask? The treatment looks like this. We've got 80 beds. We've got 2 16-bed units for inpatient crisis stabilization for adults 18 and over. On the continuum of care, we've got a partial hospitalization, an intensive outpatient for addiction and co-occurring. We also have a full outpatient practice. We do have a continuum of care for eating disorders, for inpatient, partial hospitalization, intensive outpatient, and the Harold C. Schott eating disorders outpatient team. We do work with neuromodulation for treatment-resistant depression, for with electroconvulsive therapy, ECT, and also TMS, transcranial magnetic stimulation. We have a residential side offering, 2 units, 16 beds each. One is called Williams House, where we're stabilizing, we're doing detox, medication management, and evaluating, doing an evaluation. We also have a residential unit called Sipsey House, where we're doing a comprehensive diagnostic assessment. We're surrounding an individual. These are both for 18 and over. We're surrounding the individual with a psychiatrist, psychologist, social worker, and we are teasing out what is going on and creating a blueprint. Also, we have something called rapid access, where folks that are working to get into a psychiatrist, we can, even if they're not working to get in to see a psychiatrist, they can come in 2 afternoons a week and have a full assessment with a psychiatrist and a social worker, and get medication if needed. They can come back for 3 appointments, and we can then work to try to help them get into a psychiatrist at the Lindner Center or somewhere else. So we're doing a lot of treatment at the Lindner Center of Hope. Did I forget anything? Rapid access. We I don't think so. I think I've hit it all, but we've got some specialties. We work with OCD, we work with addiction. If I can be of help, I'm Maria. Don't hesitate to reach out. Put your name in the chat, and Bob can send you my contact information. Of course, our residential offering certainly supports the reach globally. And then, of course, we do have a lot that we can offer locally, but also we have in that continuum the opportunity for folks to step into other services at the Lindner Center. So we take a lot of commercial insurance and some private pay, and let me know if I can help. Thanks for being here. I'm gonna turn you over to Dr. Danielle Johnson. She's our Chief Medical Officer. She's the Director of Women's Mental Health Program, the Assistant Clinical Professor at the University of Cincinnati College of Medicine, Department of Psychiatry and Behavioral Neuroscience. We're going to learn more tonight. So understanding depression and anxiety after giving birth.
Thank you, Maria.
Thank you.
So thank you everyone for being here. So I gave this presentation a few years ago, actually, but I've updated it. The one thing I failed to update is the title, because we're not just going to talk about postpartum depression and anxiety. We'll talk about depression and anxiety throughout the perinatal period. So you may often hear or see the term PMADS, PMADS, which is perinatal mood and anxiety disorder. So that's what we're going to be talking about this evening. So I want you to leave here understanding the signs and symptoms of postpartum, well, actually perinatal mood and anxiety disorders, and understanding the risks and benefits of treatment for these disorders. So again, talking about perinatal mood and anxiety disorders, understanding that there's more than postpartum depression, although that's what most people are familiar with. They can occur during pregnancy and or up to 1 year postpartum. Psychiatrists and other mental health professionals use something called the DSM, the Diagnostic and Statistical Manual, to diagnose perinatal mood and anxiety disorders, but most of them aren't even listed in that manual. The only one that really is called Major Depressive Disorder with Peripartum Onset. And in that manual, it occurs during pregnancy, and 4 weeks postpartum is how they define it. But the American College of Obstetricians and Gynecologists and the World Health Organization, many other organizations recognize that after giving birth, you can have these symptoms up to a year later. And not only do they include mood disorders, but also disorders of anxiety and thought. So first, we're going to talk about something called the baby blues, which is not actually a disorder, but it's very common. So I want you to understand what it is. And this cartoon is a very good example of that. It's not uncommon for new moms to be asked if they need something, and they will answer no, but they are really thinking something else. So she's saying, I need a home-cooked hot meal, I need a shower, I need a break. I need some time to myself. I need some sleep. I need someone to understand how bad I feel sometimes. I need time, rest, help, food, hugs, support, cookies, quiet, nourishment, help with laundry, cleaning, cooking. I need acknowledgement, understanding, and support. So with the baby blues, this is extremely common in up to 80% of mothers. And before I move on, I will just say that it is well understood now that everyone who gives birth does not identify as a mom. There can be people who identify with different pronouns or who are transgender who may give birth, but most of the literature still uses the term mother or woman. So that's why you will see that here, but I just wanted to point that out. So again, 80%. Usually it happens about 3 to 5 days after giving birth, and it resolves on its own within a week or two without treatment. So there can be crying for no reason. People can be very impatient, irritable, restless, anxious, very fatigued, trouble sleeping, feel very sad, have mood swings, and concentration is poor. But again, goes away on its own, no treatment is needed. It's very common. And it will be different from depression. And an example of depression, you will see that this example is a more extreme. She's overwhelmed, terrified, sleep deprived, feels sorry she had the baby, but she loves the baby, doesn't feel good, doesn't know what she's doing, can't think straight, doesn't recognize herself, doesn't feel like herself, is irritable, miserable, and can't breathe. So with depression, symptoms have to last at least 2 weeks. For it to be considered a depressive episode. It happens to about 10% of women during pregnancy and 15% during the postpartum period. Now, according to the DSM, someone has to have 5 of these 9 symptoms, and one of them has to be depressed mood or irritability, as well as loss of interest or pleasure in things that someone is normally interested in. And that can lead to someone withdrawing from their family and friends, isolating, and it can lead to difficulty bonding with the baby. There can be changes in weight or appetite up or down, trouble sleeping, and this is completely unrelated to how the baby is sleeping. Now, psychomotor retardation or agitation, that means feeling slowed down or feeling restless. Loss of energy, fatigue, feeling worthless, guilty, shameful, or inadequate, trouble concentrating or trouble making decisions, and thoughts of harming self or the infant. If there are any of those thoughts, that is an emergency. Someone needs to get treatment as soon as possible. And we'll talk about that more later. So what are some risk factors for postpartum depression, perinatal depression, and other PMADs? They are multifactorial. There is not one cause. You will see here that there are a lot, but some that I will point out: a personal mental health history, family mental health history, hormonal changes, insomnia and sleep disturbances, that is a huge one. Adverse childhood experiences. So those are called ACEs. And those are things such as, there are a lot actually, but things such as witnessing your parent being abused, having an incarcerated family member, having a family member who abused substances, experiencing housing insecurity when you were a child, a history of abuse when you were a child, things of that nature. So adverse childhood experiences, intimate partner violence or other abuse, pregnancy loss, of course, other traumatic birth experiences, having a baby in the NICU, breastfeeding difficulties is another big one. Racism is another big one. Postpartum depression is higher in certain racial groups. Age, teenage pregnancies and older pregnancies, low socioeconomic status and education level, unwanted pregnancies. So those are some significant factors. So we talked about hormones, and this is just showing across the female life cycle how depression responds in relation to estrogen levels. So you can see that a first episode of depression typically occurs when puberty starts. And then the risk remains high throughout a woman's life cycle of menstruation. And then the greatest risk is postpartum, when there is a significant drop in estrogen. And then another high risk time is with perimenopause, when there is another decline in estrogen. There don't seem to be high levels of depression after perimenopause when estrogen is low again. So it seems to be when there is the initial first increase in estrogen, when there's significant drops in estrogen, and estrogen fluctuations are times when people are really vulnerable to depression. So I want to move on to talking about hypomania and mania, because when someone is diagnosed with depression during or after their pregnancy, it's important to know if they could potentially have bipolar depression. Depression can come in two forms, either bipolar or unipolar, which is major depressive disorder. And the reason it's important to know this is because the treatment is very different. So anyone who's being treated for and screened for depression during their pregnancy should also be screened for bipolar disorder as well. So actually, up to 54% of women with postpartum depression actually have bipolar disorder. For women with bipolar postpartum depression compared to women with bipolar disorder who are not postpartum, their risk of hospitalization is 23 times greater within 30 days after delivery. So symptoms of a manic episode, and it is, so the mood can be elevated or expansive, which is kind of euphoric, or irritable. If someone has an irritable mood, they have to have at least 4 of these symptoms. If their mood is elevated or expansive, they need at least 3 of these symptoms. So that includes rapid speech, a decreased need for sleep, so they're not sleeping well and they don't feel tired. Their thoughts are racing, they're very distractible. They have increased activity or they're restless. They're very impulsive or do things that have poor judgment. They're grandiose, inflated self-esteem, and they could have delusions or hallucinations. So delusion is a fixed false belief, and hallucinations, hearing voices or seeing things. So mania is with bipolar type 1, and those are symptoms lasting at least 7 days. They have marked impairment in social and occupational functioning. They could end up being hospitalized, and they might have psychotic symptoms, which are delusions or hallucinations. For hypomania, which is bipolar type 2, symptoms last at least 4 days. Their impairment is not marked, and they will not be hospitalized, and they don't have psychosis. So risk factors for bipolar disorder in comparison to major depressive, they tend to be younger. An unplanned pregnancy, they have prenatal bipolar symptoms, a family history of bipolar, and their depression occurs immediately after delivery rather than months later. So differences between bipolar versus unipolar or major depressive disorder. Depressive episodes tend to be brief. They tend to be seasonal, so people tend to have depression in the fall and winter and mania in the spring and summer. They can have mixed episodes, which means a combination of depressive and manic symptoms. They can be agitated and have psychotic symptoms. They have a very high number of previous episodes. They have atypical features, so hypersomnia, meaning they sleep too much rather than having a decreased need for sleep. Leaden paralysis, which means a heavy feeling in arms and legs and increased appetite. And then having a response to antidepressants with mania, hypomania, mixed symptoms, or they either respond very poorly or rapidly to antidepressants. So we've finished the major mood disorders. We are going to move on to anxiety. So a few examples of that. I just don't feel like myself. This isn't who I am. I used to be so confident, so carefree. Now I'm nervous all the time and I can't stop crying. I don't know what's wrong with me. This is what being a mother feels like. So in this one, she's asking, how do I know if I have too much anxiety? The doctor's saying everything is just fine. You just had a baby. It's normal to feel this way. But she's thinking, this can't be normal. You have no idea how bad I feel. Is it normal to stay up and check that the baby's still breathing every hour throughout the night? And then this one, why do I feel like I can't breathe? I have this pit in my stomach. I'm so nervous all the time. My heart is racing, my head is racing and racing. I feel like I had too much caffeine, but I didn't have any caffeine. My heart is pounding. My thoughts are spinning round and round. I'm nauseous, I'm dizzy. Maybe I should go to the ER. What is wrong with me? Other moms do not feel this way. These are very common symptoms of a panic attack, by the way. So some anxiety disorders are generalized anxiety disorder, panic disorder, and social anxiety disorder. The prevalence varies during pregnancy and in the postpartum period, with generalized anxiety overall being the most common. Various risk factors, very similar to the risk factors for depression. The ones I want to point out in particular, poor quality relationships, family history of anxiety, adverse circumstances around the pregnancy and birth, and history of abuse, high stress, being single, unplanned or unwanted pregnancy, and also thyroid disease. So there's something not included in the DSM, but it's included in research literature called pregnancy-related anxiety. And this is in particular when people have concerns about their child's health and concerns about the birth without a previous anxiety disorder and not meeting full criteria for another anxiety disorder. So anxiety is something that everyone has. It's kind of our body's way of telling us that something's wrong. It alerts us to danger. Everyone has anxiety. So these are examples of how you know if something is normal anxiety versus an anxiety disorder. So for generalized anxiety disorder, it's normal to worry about bills, getting a job, a breakup, or other important life events. But if you worry constantly, the worry is unsubstantiated, it causes you distress and it interferes with daily life, then that is generalized anxiety disorder. It's normal to be embarrassed and uncomfortable or awkward social situations. But if you avoid social situations because you fear being judged, embarrassed, or humiliated, that is social anxiety disorder. It's normal to be nervous before a test, a presentation, stage performance, or other events. But if you have out of the blue panic attacks and you're preoccupied with fear of having another one, that is panic disorder. A realistic fear of something dangerous is normal, but if you have an irrational fear or avoidance of an object, place, or situation that poses no threat, that is a specific phobia. Anxiety, sadness, or difficulty sleeping immediately after a traumatic event is normal, but having recurring nightmares, flashbacks, or emotional numbing related to a traumatic event that occurred several months or years before, it's post-traumatic stress disorder. It's normal to make sure you're healthy and living in a safe, hazard-free environment, but if you are performing uncontrollable repetitive actions such as cleaning, checking, touching, and arranging, that is a obsessive compulsive disorder. So we are going to talk about PTSD and OCD in more detail because I think those often go missed during the perinatal period. So for PTSD in particular, 50% of women report their labor was traumatic. And that could be, it doesn't have to be a physical trauma. It could be that they feel they were not listened to. They feel they were ignored, mistreated in any way during their pregnancy. 3 to 15% will develop PTSD. A trigger warning for anyone who experienced any of these events. For those who with stillbirths, the prevalence increases 25% and 30 to 35% if there was a death of an infant in the NICU or PICU. So symptoms, as I mentioned earlier, re-experiencing the traumatic event and its intrusive thoughts, flashbacks, so vivid memories or nightmares of the event. You avoid any stimuli associated with the event. That could include not wanting to drive past the hospital where you gave birth, not wanting to see specific clothing, not wanting to talk to specific people, etc. Increased arousal, so being irritable, having trouble sleeping. Hypervigilance is being super aware of your surroundings, constantly on watch, and startling easily, anxiety and panic attacks, and feeling like things are unreal or feeling detached. And then some of the risk factors are traumatic things that occur during delivery, having an infant in the NICU, again, feeling powerless, poor communication, lack of support during the delivery, other severe complications, and then previous sexual trauma for someone who experienced that, having multiple gynecological exams during the pregnancy process can be traumatic. Although it's not listed in here, I've also seen women who have had very difficult relationships with their mother, whether it's been verbal, emotional abuse, abandonment, adoption, etc. They have had PTSD trigger when they become a mother for the first time as well. So we are moving on to obsessive compulsive disorder. So she is thinking, and another trigger warning here, I think my baby would be better off with another mother. I think I made a huge mistake. I think I will find my baby dead in her crib. I think my baby will fly out of her car seat into a ditch. I think I will drop my baby onto the cement when I'm going down the stairs. I think I am unfit to be a mother. So those are all very morbid thoughts, but that is not uncommon with postpartum OCD. The thoughts are unwanted. They are out of the mom's control. She does not want those thoughts. She knows they're not normal. And we'll talk about later why it's very important for providers to know that these are obsessions and not delusions. So the prevalence, so the numbers that I quoted here are from one study, but I have seen numbers much higher than this in other research. But 2 to 5% during pregnancy or postpartum, 2 to 4% have their first onset postpartum, often rapid. If there's already a history of OCD, it's 25 to 75% recurrence during the postpartum period. So risk factors are permiparity, which means first pregnancy, the early postpartum period, so within the first month. History of depression, obsessive compulsive personality disorder, avoidant personality disorder, and OCD-related functional beliefs, as well as family history, mood, anxiety, and substance use disorder. So again, obsessions, they're unwanted, intrusive thoughts, or mental images that can be violent or sexual. Compulsions or actions to reduce the obsessions. It can be washing, checking, counting, organizing things, avoidance, prayer, seeking reassurance. And sometimes they can interfere with caring for the infant. So for example, if someone has an obsessive thought that every time they bathe the baby, the water is going to be too hot and they could burn the baby. That might lead to them not wanting to bathe the baby. They are horrified about the obsession. Sometimes might fear being left alone with the baby, or they are overprotective of the baby. And again, they know the thoughts are not normal, and it is very unlikely that they would ever act on the thoughts. And again, why is it so important to know what types of thoughts these are? So she is being asked if she's feeling any better today. Not really. I mean, I'm anxious all the time. I still can't eat. I'm worried I'm going to do something that will end up hurting my baby. Then asked, do you think you could really hurt your baby? I don't think so. Do you think I could really hurt I could hurt my baby? And if she's thinking, why did I say that? Now she thinks I will hurt my baby. If she's worried, shouldn't I be worried? What if she calls Child Protective Services? What if I do hurt my baby? Should I be in the hospital? I can't go to the hospital. Does she think I'm crazy? Am I crazy? So what can happen if someone does not know the difference between obsessions and delusions, or knows that it's an obsession but doesn't know that the risk of her actually acting on the thoughts is low, is that she could be hospitalized when actually she probably needs to have outpatient therapy and medication management, and Child Protective Services gets called when that is not necessary, and causes more trauma than needed. So the difference between obsessions and delusions, and I'll give another trigger warning because the example they give is morbid. So obsessions, and again, reiterating, the intrusive thoughts are unwanted and distressing. They can be sexual, religious, or violent. No desire to act on the thoughts. They avoid to check or reassure. To ease the distress. They have insight, so that means they know there's something wrong. There is no distorted reality. So she has intrusive thoughts about throwing the baby out the window, so she will lock all the windows, close the blinds, check the locks, and refuses to go to the side of the room where the windows are. For a delusion, and delusions are a psychotic symptom, and this will occur in something like postpartum psychosis, which we will talk about next. So the intrusive thoughts may be unbidden, but they do not cause distress. So it generally does not bother the person because they don't realize that something is wrong at the time. They can also be sexual, religious, or violent, but the content is bizarre or unusual. They want to or feel compelled to act on the thoughts. There's generally no accompanying compulsive behavior. There is a significant lack of insight that their thoughts are bizarre or that there's something going on. Reality is distorted. Sometimes it can appear like delirium. So sometimes cognition can be distorted, appears disoriented, have memory lapses, but then maybe later in the day, she appears to have normal cognition. So it can fluctuate as well. And so in this example, mom believes child has sinned and that God has commanded mom to drop the child out the window to punish the sin. And these are the types of examples that we'll see in the news sometimes. So with postpartum psychosis, it's rare, but it's scary. So 1 to 2 of 1,000 deliveries. It can lead to a 5% rate of mom hurting the baby or hurting herself because she has delusions that by killing the baby or killing herself, she is doing something, kind of getting them to a better place often. 20 to 30% of women with bipolar disorder develop postpartum psychosis. So significant correlation there. So the first onset of affective psychosis, affective means mood related, 23 times higher within the first 4 weeks postpartum compared with any other period during a woman's life. Postpartum psychosis is a psychiatric emergency. That means immediate treatment is required. This is not something that you wait until the next doctor's appointment, or you wait and see if, she might feel better within a few days. If you notice symptoms like this, if she has a physician already, you call them. If she doesn't, you need to get her to an emergency room. So risk factors, again, first pregnancy, personal or family history of bipolar, previous psychosis, and severe sleep disruption. Sleep disruption, of course, is not uncommon after having a baby, but generally to the point where people are getting 1 to 2 hours of sleep or no sleep at all. This is often impacted by breastfeeding, someone who has trouble latching, and breastfeeding, attempts to breastfeed are causing significant trouble sleeping, or someone who doesn't have any help with nighttime feedings, like she's the only one getting up, she's not pumping, doing any bottles, so there's no one else helping with nighttime feedings. So it's important that there's someone to help with nighttime feedings. It's okay to pump, it's okay to use pump milk to feed the baby and let someone else do nighttime feedings. If breastfeeding is difficult, it is okay to give mom permission to stop breastfeeding. Do not shame women if they decide to not breastfeed. Any amount of breast milk the baby got is better than none. Sometimes mom getting sleep is more important to prevent something like this from happening. So all of that to say sleep is very important, especially for someone who has previous risk factors, and giving mom as much help as at nighttime as possible is very important. So early symptoms, insomnia, fluctuations in mood, irritability, hyperactivity, and noticing any mood symptoms, mania, depression, or mixed symptoms, delusions, disorganized behavior, obsessive thoughts about the infant, appearing delirious, and hallucinations. And then we definitely don't want any of these disorders, whether it's mood, anxiety, or psychosis, to end up with someone not wanting to be here anymore. So she can't stand the way she feels. She just wants to sleep and never wakes up. Feels baby deserves a better mom. Everyone would be better off without her. She can't do this for one more day. She's not sure she wants her life to end or her suffering to end. Isn't it the same thing? So suicide accounts for over 5% of perinatal deaths, most frequently at 9 to 12 months postpartum, and more likely to do so by lethal means. So in general, men choose lethal means of suicide more often than women. So what that means is like firearms, stabbing, hanging, compared to pills. But for perinatal suicide, women choose more lethal methods like firearms, etc. For those who completed suicide during this time period, they had higher rates of prior psychiatric illness. And again, suicidal thoughts require immediate intervention. So if there are suicidal thoughts of harming the baby, or there's psychosis, do not wait. Immediate treatment is needed. So we are going to talk about some treatment. These are not treatments that I'm recommending. Treatment is very individualized, as it says on the bottom. All decisions should be made jointly with the person's provider, full knowledge of risk and benefits. These are generalized recommendations based on treatment algorithms. This one is by the American College of Obstetricians and Gynecologists and the American Psychiatric Association. So in general, this is particularly for treatment during pregnancy. Ideally, if someone has a history of depression and they want to get pregnant, we'll do what's called preconception counseling. So we will plan what to do with medication before someone gets pregnant. So the recommendation is that there's a history of depression and there are mild to no symptoms for greater than 6 months, or at least 6 months or more. You can consider tapering off your medication. But if you have a history of moderate symptoms or a history of severe recurrent depression, discontinuation may not be appropriate because you're at a higher risk of relapse during pregnancy, and higher risk of postpartum depression. Now, if you are already pregnant and taking antidepressants, if you're stable, could be okay to taper off. If you're someone, moderate symptoms, could be okay to stay on after discussing the risk. If symptoms are severe, it is not recommended to discontinue your medication. And relapse rate is high, symptoms should be monitored regularly, and psychotherapy should be considered. If you're pregnant, you have significant depression, and you're not already taking medication, you can consider psychotherapy before starting your antidepressant. But if antidepressant is preferred, of course, discuss risks and benefits and other factors such as age and history of depression. And then, as I already said, if someone is pregnant and there's suicidal symptoms or psychosis, immediate intervention is required. It's important to let someone know, especially if there's hesitation about taking medications during pregnancy, that there's also risk of untreated depression during pregnancy as well. So if someone has depression during their pregnancy and they are either untreated or undertreated, meaning they might be on medication, but their symptoms aren't in full remission, or maybe they're taking some supplements and their symptoms aren't in full remission, there's still risk to mom and baby of depression by itself. So it's important to have that discussion. So with untreated depression, there's no association with congenital malformations or birth defects. There is an increased risk of spontaneous abortion, and that's miscarriage. The increased risk of preterm birth, and that's the same as early labor. Increased risk of low birth weight. Short-term outcomes are impaired bonding, decreased length of breastfeeding, and of course, an increased risk of postpartum depression. And then long-term, there can be cognitive and behavioral problems. Particularly for SSRIs, or selective serotonin reuptake inhibitors, and those are the most common antidepressants used, particularly during pregnancy. So initially, there were some studies that showed an association with cardiac lesions, particularly ventricular septal defect. But there's more data, data is higher quality, confounders have been controlled for, and it's not showing those associations anymore, even with exposure in the first trimester. There's no increased risk of spontaneous abortion. There is a possible additional increased risk of preterm birth, possibly low insignificant impact of low birth weight. So short-term outcomes. There was an association with something called persistent pulmonary hypertension in the newborn, but the overall absolute risk is low and usually mild. And then something called neonatal adaptation syndrome, meaning the baby could have withdrawal from the medication itself, but those symptoms are brief, about 24 to 48 hours, also not requiring intervention. And then no additional increased risk of long-term outcomes. So people often want to know about natural remedies that they can use instead of medications. So omega-3 fatty acids, this has been shown to be beneficial as an adjunct to standard treatment with 1 gram of EPA plus DHA. Folate, modest support for an antidepressant effect, but it's beneficial in general because it reduces risk of neural tooth defects, and recommended 600 micrograms, and particularly could be helpful if women have low serum folate levels. Physical activity can reduce postpartum depression, less evidence for prenatal depression, but as long as your OBGYN has no issue with it, there's no reason you can't do it. Yoga can be beneficial for prenatal and postpartum, lowering perinatal depression. Bright light therapy is another option for women who do not want to use medication. I have to look at my notes on this slide. I had a couple other things here, sorry. Acupuncture and massage. So there is some information that it could provide benefit in the treatment, but it should not replace more standard therapies. There's also been some studies about supplements like SAM-E, SAM-E, but there are some concerns about safety during breastfeeding, so that one has not been recommended. So some other things that can be considered. So people who have responded well to hormones in the past, such as people who have a history of premenstrual syndrome or premenstrual dysphoric disorder and have used hormonal contraceptives to treat that with a positive effect, could have a positive response to postpartum depression with those. However, if you're breastfeeding, there has to be caution with the type of oral contraceptive that you use. So that's something that you have to use caution with. Sometimes sleep disorders can impact depression. So having evaluation for things like restless leg syndrome or sleep apnea can be beneficial. Sleep hygiene is very important. There's a therapy called CBT for insomnia that has shown significant benefit for perinatal insomnia, and it has even showed benefit in improving the symptoms of depression and anxiety. For people who have had attachment issues in life that have contributed to their depression, there are certain types of therapy that can be beneficial. The same with people who have had adverse childhood experiences that have led to certain personality types. There are specific therapies such as DBT that can be beneficial. For people with certain social stressors, mindfulness-based therapy can help. And for those with trauma, definitely trauma-focused therapy can be beneficial. So particularly for SSRIs, I have this website on my list of references. They have a list of all of the antidepressants, but I only put the SSRIs on here, but you can go to this website to see all of the antidepressants. So when we're looking at someone who has never been on a medication, someone who's medication naive, if we were to consider what we want to start someone on during pregnancy and for someone who was considering breastfeeding, most people would choose sertraline, which is Zoloft, because it has the lowest amount. Well, actually not the lowest, paroxetine does, but it's not well tolerated. But it tends to be best tolerated, as well as having the lowest amount of breast milk. So most people are started on sertraline if they've never been on a medication before. As I mentioned, paroxetine has a lower amount, but paroxetine is not well tolerated by a lot of people because if you miss the dose by even a few hours, you can have withdrawal symptoms. You'll see that escitalopram, which is Lexapro, also has the same amount in breast milk, but it hasn't been around as long as sertraline, so there's less data. So people tend to stick with sertraline when starting someone on an antidepressant for the first time. But in general, if someone has been on a medication, they are someone who should stay on medication during their pregnancy because they have a history of severe episodes or several episodes. They have not done well off of medication. We will tend to keep them on the medication that they have done well on, especially if they are found out they're pregnant and they're already on medication. It's best to just leave them on what they're taking rather than stop the medication, start something new and expose the baby to a second medication. So in general, if someone is stable, they find out they're pregnant, we will keep them on what's working for them at the lowest, most effective dose throughout their pregnancy. And then these are antipsychotics. Antipsychotics are used for not only psychotic disorders, but also for bipolar disorder. And sometimes they are used as adjunctive treatment in depression. So if we were again looking at someone who has never been on a medication and needed to be on this type of medication, we would generally start with quetiapine, which is Seroquel, because it has the lowest relative infant dose. It can be sedating, but a lot of women have trouble sleeping during their pregnancy, so that could be beneficial. Again, if someone was stable on one of these medications, and we did not want to change anything for the most part, the only one that might give someone pause about keeping them on it during their pregnancy is possibly clozapine. If the woman wanted to breastfeed, because there are some concerns with that during breastfeeding. But for the most part, if someone was stable on one of these medications, we would probably still keep them on it. A lot of these types of medications, so some of these medications are called second generation or atypical antipsychotics, and the top two are called first generation typical antipsychotics. There's less data about the second generation antipsychotics, but we are getting more data. The data that we do have so far is not showing any major malformation, so still considered overall safe to use. And again, the risk of mom being on medication is often less than mom being off medication, particularly. So I showed you the risk of untreated depression, but the risk of untreated mania or psychosis could be even worse, because mom could be more likely to have dangerous behavior towards herself or towards the baby. So we really have to consider those risks as well when considering taking a woman off of these medications during pregnancy. Then moving on to mood stabilizers. These are medications that are used particularly for bipolar disorder. Again, overall safest are the typical or first generation antipsychotics, and mainly because they've been around the longest and we have the most data on them. Lamotrigine, which is called Lamictal, no increased risk in teratogenicity or birth defects and no delay in neurodevelopment. Ones to be used with caution, atypical antipsychotics. And again, mainly that's because there's more limited data, but so far, no indication of major malformations. Lithium, there is a risk of something called Epstein's anomaly, which is a cardiac defect. However, if someone has a history of bipolar type 1, particularly, and lithium is the medication that has kept them stable. You know, they've been on other things, nothing else has worked. There are many women who have gone through their pregnancies on lithium. They're just monitored more closely. The baby has to have cardiac ultrasound at a certain number of weeks, and mom and baby have been fine. Carbamazepine, which is Tegretol, there is an increased risk of cleft lip and palate. Things like reduced head circumference, lower birth weight, and shorter limbs, so that one is not preferred. And then valproic acid, which is Depakote. This is one that we try to avoid, even try to avoid prescribing it in general in women of childbearing age. This is one that if someone has to be on it, we want them on contraceptive, because we just don't want anyone to get pregnant while they're on this medication, because there are so many malformations associated with it, particularly neurotube defects, and also long-term neurodevelopmental issues. And then moving on to other treatment options. So ECT, or electroconvulsive therapy, this can be used during pregnancy and postpartum. It is not a danger to mom or the fetus. There is a slightly increased risk of preterm delivery. So when ECT occurs in a pregnant woman, it's recommended not only is a psychiatrist there, but anesthesia, as well as OB, just in case preterm delivery were to occur, but it is a very low risk. However, considered to be effective for refractory symptoms, life-threatening depression, also for psychosis or mania that is not responding to treatment. TMS or transcranial magnetic stimulation, also for treatment-resistant depression, no severe side effects to mom or fetus. S-ketamine and ketamine, they are not FDA approved specifically for postpartum depression, but they are FDA approved for treatment refractory depression. But there are some positive trial case reports of them being effective for postpartum depression. Brexanolone is Zulresso. It was the first medication FDA approved specifically for postpartum depression. It requires a 60-hour IV infusion in a monitored setting. It's only available in certain locations across the country. You know, mom has to be away from her family for 3 days. She has to stop breastfeeding during that time. So it probably is not as widely used as it could be. Zuranolone, I cannot remember what the brand name of this is going to be, but it was FDA approved in August, if I remember correctly, not on the market yet, but it will be a 14-day at-home treatment, oral treatment for postpartum depression. So that is very exciting. This is the book where those cartoons came from. So it is just a good resource for people who wonder if their thoughts are normal or not during pregnancy. Good moms have scary thoughts. These are some resources. Locally, we have a group called A Lighter Shade of Blue, a postpartum depression support group in Ohio. POEM, Perinatal Outreach and Encouragement for Mom, has Ohio resources for Ohio-based support. UC Health, which is a Cincinnati-based health system, has a perinatal support group. Postpartum Support International has a helpline that can give you resources in your area. They also have a ton of virtual support groups for various, probably just about anything you can think of, for pregnancy loss, for dads, for different demographics, etc. The Suicide Prevention Lifeline, the Crisis Text Line. The Mother Baby website has medication information about just about every medication during pregnancy and lactation. And then Sage is the company that makes Zulresso and Zuranolone, and it has some more information about those medications and just more patient support. And then these are all the resources I used for my talk. And now we have time for questions.
For you folks that are out there in joining us via Zoom, you can either, if you have a question, you can either type it into the chat and I will happily ask the good doctor, or you can unmute your microphone if you so desire and actually ask your question and she will hear you.
Dr. Johnson, is there much data about like anti-anxiety medications, like during pregnancy, or any medications that could be applicable for OCD?
Yes, so for OCD in particular, the SSRIs are the most common medications used, so it'd be the same data that I presented for SSRIs, but particularly other kind of anxiety medications that you might think about, like benzodiazepines that are used as needed. There is some data, particularly if they're used in the first trimester, that they have some risk. Some concerning issues, and also in the last trimester, there's some concerns with benzodiazepines. However, if absolutely necessary, there's nothing else that will control someone's anxiety. It's recommended that they be used lowest possible dose, as little as possible. So it's not an absolute contraindication, but I would say they aren't preferred. Yeah.
Is Moving Beyond Depression still a program available to postpartum mothers in Hamilton County?
I'm not sure, actually. I would have to look that up. Not familiar with it.
Lauren, do you have the opportunity? Can you unmute and maybe expand a little bit on that?
Yes, so I'm a nurse practitioner at South Avondale School-Based Health Center. I also used to work at Hopple Street Clinic, and I know that it was an in-home mental health service that was provided by, if we referred a patient's mother there. So I didn't know if that was still something, because I hadn't heard about it in a little bit, so I was just making sure that was still something we could refer people to.
I'm looking it up and it says it's still on Burnett Avenue, so I assume so. Their Every Child Succeeds.
Okay.
Yeah,
And
it's that in the chat, Doctor, just so you know, and also for you, Lauren, it says the same thing. It says, yes, it's still available through Every Child Succeeds.
okay. And then is this recorded?
Yes, it is recorded.
Okay.
And then the recording is then given to the Lindner Center of Hope and they put it on their website.
Okay, thank you so much.
But thank you for mentioning that program because I wasn't aware of it, so I definitely want to look it up and learn more about it.
I got a question. I wondered about the pregnancy related anxiety. Normally, does that, expand after the baby's born? When we talk about gestational diabetes, now we know how that can be just during the pregnancy, and then yes, it can become full blown after the pregnancy. Is this pregnancy related anxiety something that does not a little, or it can basically become even worse?
Yes, so it can develop into an anxiety disorder. Like, as I mentioned, it's not something that's like recognized in the DSM as a disorder. Unfortunately, a lot of these perinatal disorders aren't actually in the DSM. But just about every disorder has a perinatal or postpartum onset. But particularly this pregnancy related anxiety doesn't necessarily meet the full criteria for an anxiety disorder, but yes, it can develop into an anxiety disorder.
Anybody else have any other questions that they would like to put in the chat and or to unmute their microphone and ask? I'll give it a minute in case people type like I do.
Hi there. This is Dr. Caitlin Bruns. I work at UC Psychiatry specifically. I'm going to be starting a program with rural teen moms. And I unfortunately joined late because I was dealing with the crisis. But I'm wondering, are there any, and I apologize if you already spoke about this, and if you did, I can just watch it later, but any special considerations for working with teen moms in terms of perinatal mental health?
We don't have a program specifically for teen moms, but I have no issue with working with teen moms. We definitely have done that, but I would say we don't have programming specifically for teen moms. I would, unfortunately, I think part of the reason for that is many of them probably get referred to places other than us, programs that are specifically for that demographic. I'm going to guess that's why, but I certainly would have no objection to working with younger moms.
Okay. Okay. Thank you.
You're welcome. And feel free to send me information about your program.
Yeah, sure thing. Thank you.
Yeah, I have a UC email and a UC Health email, so you'll be able to find it.
Okay, perfect. Thanks.
Any other questions, comments? There is a lot of comments in the chat, Doc, just saying. Absolutely outstanding. Thank you so much. A lot to digest. So maybe questions later.
Thank you, everyone. Thanks for attending.